Hi everybody, welcome. The Royal Australian and New Zealand College of Ophthalmologists, members and participating guests wish to acknowledge the Aboriginal and Torres Strait Islander people of this country. Sovereign custodians of country, we acknowledge their continuing presence and their contributions made to the college and the communities we work in. We will respect past elders and communities and will continue to live, work and interact in a respectful manner with present and future elders and communities. The Ransco Reconciliation Action Plan reflects the message of its First Nation engagement. We're delighted to have you all here to join us today to the Paediatric Refresher course for all ophthalmologists who see kids. We're passionate about increasing everyone's confidence and expanding your skill sets in seeing paediatric patients. I am Dr. Chanel Sharma and I'm a subspecialist trained paediatric and strabismus ophthalmologist based in Sydney. I also want to introduce my co-chair, Dr. Marie Flaherty, who requires no introduction. She's a leading paediatric ophthalmologist, also based in Sydney, with over 30 years of experience in managing paediatric eye problems in Western Sydney. She has a long-standing VMO appointment with the Children's Hospital at Westmead. I'd like to introduce our panel. Professor James Elder is a very well-respected and leading paediatric ophthalmologist in Melbourne with extensive experience at the Royal Children's Hospital and is the immediate past chair of the Paediatric Special Interest Group, which he held for over 10 years. He's also on the committee for the Australian and New Zealand Strabismus Society. He holds an academic appointment with the Department of Paediatrics with the University of Melbourne. Dr. Trent Sandico is a general ophthalmologist with a strong interest in paediatric ophthalmology and strabismus. He works in Northwest Sydney and has public hospital appointments at Westmead Children's Hospital, Liverpool Hospital and Canberra Hospital. Russia Eltier is a senior lecturer and well-respected paediatric ophthalmologist in Auckland. She's at the University of Auckland and the visiting medical officer for the Blind and Education Network in New Zealand. Her interests in paediatric anterior segment, ophthalmology and ROP, and she's missing in action. To commence, we are starting with Associate Professor Lauren Rose, who is our expert in myopia assessment and management. She's based in Sydney with both the public and private clinical ophthalmic practices and academic positions with 2 major universities. She has recently completed her PhD in myopia management. She's very passionate about teaching and is a founding member of Myopia Australia. Thanks for sharing your expertise in myopia assessment and management for all of us ophthalmologists who see kids.
Thank you, Chanel. So welcome everybody and thank you for the opportunity. So I'm going to start with talking about myopia in children. So I'm going to start by showing you that it's changing. Okay, I'm going to start from the first slide saying that it's a pleasure to be here. I'll be talking about myopia management in children, which I think is a rapidly evolving area in paediatrics. So the diagnosis is very important and it's very important to consider this as a almost new disease. Don't know why it's deciding to do its own thing. Sorry. Can you stop the flow? So I'll just start by saying the diagnosis is super important, mainly because we'll be seeing more and more. Can you quickly do that and I'll start? Thank you. Sorry about that. So I'll just start by saying that in 2050, half the world is projected to be myopic. And so we'll be seeing more and more children with myopia. We know the incidence is growing. We know the onset of myopia is earlier. So we're talking about a condition that's becoming more frequent and higher myopia is associated with pathological disease. I'm waiting for my slides to start. Sorry. Okay, we'll try again. So, it is important when you see a child that we do cycloplegic refraction. I'm just highlighting that an under 12-month-old needs weaker cyclopentolate. Retinoscopy, autorefraction only after cycloplegia. It is important to do a full exam as there is an association with divergent squints, as well as a fundus examination looking for dystrophies. I will highlight a little bit that axial length has become very much part of our tools for measuring myopia and myopia progression. And we need to assess the risk factor because we do know that there is a strong risk factor with family history. And when we see a child initially, it is important to work out their age and refraction and family history because that will be able to be then worked into an assessment for risk factor in the future if they're not myopic yet. So what we're doing now is looking at axial length as a measure of myopia and then myopia progression. That's very important because it's the most accurate way to measure progression in the future. It also is what's linked to the pathology of myopia. So you have a measure of disease or potential disease by measuring this and following this with families and explaining this to them. It is important to know what the baseline measurement of eyes are. So between 0.2 and 0.3 millimetres a year is what's been shown around the world with growth charts, and we have got a lot of data around the world about that. And we know that the growth of the eye stops on average, and not by a rule, but on average by the age of 16. So it's important to tell your families that this is something that's going to be monitored and changing in a certain fashion, and then you can actually predict whether they're going to be in a group that's progressing slowly or fast according to this. And when I do interferometry, which usually in my practice is a Zeiss machine, but it can be a bunch of new machines that are out there, then most kids can be on this machine at the age of 4. So you can get a really early age assessment. And in the future, even now, there's a whole bunch of myopia profile machines that can now give you this sort of information, which is very digestible for patients, parents and patients. Now, we do know a little bit of the lifestyle influences to myopia progression. So we talk about increasing the lux of light, and it's important to try and talk to families about increasing the outdoor exposure. About 2 hours a day is what we're suggesting. There's some studies saying 3, but at least 2 hours a day, 7 days a week. We want to protect eyes from UV light. We know that there is a lot of harm to skin and eyes, so that's important to explain to the families. There's also some important research saying that near work is part of the risk factor lifestyle that can cause higher progression. So we want to explain that devices seem to equal books, that doing less near work is important, but we don't really know what a safe level is. And finally, I would stress that it's important to fully refract your patient and give them the full refraction. There's actually some studies showing that you can progress more by under-treating. What's getting more exciting is that we have now interventions to treat myopia in children. And so one of the first preventers within the refractive department was the Hoya MyoSmart lenses. They were released in Australia in 2020. And they're basically, they have got a limit on how much refraction you can treat, but it's pretty high. And the 2-year data that was released showed almost 50% reduction in diopters and 60% reduction in axial length progression. The newer studies have shown that you can maintain the effect of these lenses, and even if you stop, you don't get rebound. So they seem to be pretty safe. The theory is that when you've got myopia, you've got an elongated eye, and if you haven't got glasses, you're out of focus and you don't see. But what's really important is that the periphery is out of focus differently. When you put a pair of glasses on, everything gets shifted back, like that picture there, but basically the periphery is still out of focus, and we think the periphery drives the growth of the eye. So these new lenses look at creating like a refractive shell to treat the periphery and to slow down progression. There are now contact lenses that do the same. So the MyoSight, they've got a dual focus, and you can see from that graph, if you compare normal contact lenses to the MyoSight contact lenses, you reduce progression by about 50%. There's also hard contact lenses, which are called orthokeratology, and they've been around for a long time. They're still quite popular because they negate the use of glasses during the day. There is an increased risk of microbial keratitis because you do wear them at night. Atropine has been something that really has changed a lot of the landscape for myopia treatment. So we had the ATOM-1, which compared 1% to placebo, and that was followed by ATOM-2, which compared moderately high doses to 0.01%. And the theory was that the low dose was going to be like the placebo. And they were surprised to find that the low dose seemed to do quite a bit, and there was some advantages with the low dose. So as of this year, this has been TGA approved in Australia, this dose 0.01%, and comes in an ampule which is preservative-free, single use, and it's TGA approved for 4 to 14-year-olds that are showing fast progression. There are some contraindications. Making the landscape a little bit more confusing, I would say, but exciting, is the LAMP studies, which now have tested atropine doses that are much lower, comparing it to 0.01. And look, I think the simple answer to all of this is that the higher the dose, the more the effect in myopia progression retardation, the higher the side effect profile, and the more rebound. So you've got to weigh these things up. And I would stress that the LAMP studies have not been reproduced anywhere else in the world. They are Hong Kong data, and there's some discrepancies in their placebo group initially at how fast they were progressing. So I do think we need to take a little bit of that on board, that our population's a little bit different. If you look at the 5-year study for the ATOM, it clearly showed that 0.01% had a place in treatment, and you can see the first bit of that graph shows that it was dose responsive. The second bit of that graph shows that when you stopped the drops, you had more rebound, the higher the dose. But overall, over a long-term use, you did come out with about a 50% reduction compared to placebo over a 5-year period, even if you stopped the dose for a year. So my algorithm of treating this is, when I see a patient, the first thing I'm going to do is assess risk. I'm going to figure out their age, refraction and family history, and that comes from your first history taking and examination. I always discuss lifestyle. I think that's important. It gives them something to look at as maybe modulating their disease progress. I do a baseline axial length measure on every one of these patients that's myopic, because that gives me their baseline for the future assessment. Now that we've got dual focus glasses, I also consider, if I'm prescribing new glasses, whether it would be, if they're in a high risk group, with parents with high myopia, they're young and they've already got some myopia on board, whether we start with dual focus lenses even at that point. And then I follow them up for 6 months period, and looking at that growth rate of axial length being more than 0.1 millimetre as a definer of fast progression. I continue to monitor, and if they are growing fast, my first dose is 0.01%, it's TGA approved and it's not off label, and I know in some of my patients it's enough. Then at 6-month intervals, if they're still progressing too fast, I consider increasing the dose of the atropine. I usually jump to 0.05%, only because I know that's got more bang for buck for myopia progression, but a similar side effect profile with other studies showing that once you're over the 0.02%, you're more likely to get side effects from atropine. So I want to give them the max effect and hopefully the same side effect. Our considered dual focus lenses as a combination. We now have one study that says that the Hoya Meyer smart lenses plus atropine might be summative. It's only one study, so it's still early days. If they want contact lenses, especially for sport or being a little bit older, I consider the dual focus contact lenses, given that they've got a disposable contact lens, so therefore a little bit safer for microbial keratitis and some retardation of myopia progression. My red flags here are a young child with high myopia. You have to consider a paediatric review. You have to consider connective tissue disease. There is lots of syndromes that are related to high myopia, and so sometimes it affects the rest of their body. The other red flag is if I've been really careful about my refraction and they still have not improved their vision. Sometimes they're progressing fast, so you've got to be sure that you've got the right refraction, but you need to consider electrophysiology. There are retinal dystrophies that sometimes don't have anything at the back of the eye that are related to high myopia and myopia progression. What's on the horizon? Well, the stellate Holt lens has actually been released as of, it looks like this. It looks a little bit different to the MySight, but it's got the same theory behind it. And as of earlier this month, they were released into the market. So they're now available in Australia. Now we have 2 dual focus lenses. The studies show about a 55% reduction in a 2-year period, published this year. In the future, there's a new lens called DOT by Sight Glass, and they're looking at changing the periphery not by refraction but by actual retinal contrast. So that's possibly a new, exciting way that we can maybe control myopia progression. Thank you. I'll leave the questions till the end.
Thank you, Lauren. Our next speaker is Dr. Jonathan Raddle, who is a paediatric ophthalmologist at the Royal Children's Hospital, Melbourne, with over 10 years' experience. And he's a subspecialist, has subspecialty experience, paediatric experience in anterior segment, glaucoma, and genetics. And he's talking on amblyopia when a child fails vision screening and the evidence-based treatment from the Paediatric trials. Thank you.
Thank you, Marie. And it's a pleasure to be here this afternoon to share these slides on amblyopia management and advice for any ophthalmologist that's seeing children. And a grateful thanks to those orthoptists that work with me in the different places that have given me much training and teaching on this topic. Amblyopia, it's a neurodevelopmental disorder of the vision cortex that arises from abnormal visual experience in early life. We suspect it when we measure decreased vision with no organic cause found. There are the subtypes of strabismic, refractive or anisometropic, deprivational, cataract, corneal scars, and the mixed mechanisms where they can all occur together. It's the most common cause of monocular vision loss in children and in young adults, and in many, many studies, its incidence is between 1% and 3%. On average, childhood screening programs, I'll talk about shortly, detect around about a 7-8% abnormality rate. A large chunk of that is refractive error and a large chunk is amblyopia. Amblyopia impacts visuomotor task abilities. It reduces vision, of course, but also there is fixation instability, there's impaired vergence control. These kids may struggle in their sports participation and then in their gross motor skills. Later on, obviously, there can be social and interpersonal distraction and loss from this condition. Perhaps it can impair mobility in older adults and their career options. So, for those reasons, we want to tackle it. And Johnny is 3. His kinder thinks that he holds things too close, and he went off for his vision screening and failed. I'm a parent. He's got parents. And we're all a bit distracted sometimes and we don't notice these things. So Johnny arrives in your consulting room, keen and enthusiastic and ready to participate. So, through experience, we don't want to show fear. We want to be prepared. We want to have thought about how to engage children. One toy, one look is a good mantra. Decrease the distractions and the clutter. Use age-appropriate vision testing. Seat the child on the parent's lap or next to the parent to get as much information as possible, and make it a game, and do it quickly. All these challenges that kids bring along. As Lauren said so wisely, a cycloplegic refraction is just the number one thing that we need. Then again, sometimes it's just good to pin the kid down. So we have screening around Australia, and I've just summarised a little bit here. Sorry to my Kiwi colleagues here, but we do try to get kids at an age where we're going to intervene and help to make a difference in their amblyopia. 3.5 to 4 is the standard age. I think that works well to catch these kids, because we are looking for the straight-eyed amblyopes, those that we can make the difference as fast as possible. The STEPS program has some great, in New South Wales, has some great evidence and a review that backs up its success. So they have regional networks of STEPS screeners that go into the early childhood centres and catch-up clinics as well. They refer around 8% of their review, and 90% of those need treatment. That's a fantastic pick-up rate. There is a small amount of referrals that are lost and don't make it to the ophthalmologists or the caring optometrists. The other benefit of these screen checks is that you can pick up other problems like developmental delay and autism. So there's some controversy around the management, or there was, around the management of amblyopia. At the population level, the lives of people with amblyopia and those without, in terms of important educational, health and social outcomes, may be difficult to distinguish. That's fighting words. And for those that are trying to prepare these programs and spend the money to find and treat these kids, we need to hit back with the evidence that it is important to improve these kids' outlook and vision in their amblyopic eye. So what options do we have? Glasses, patching, or atropine? Glasses, patching and atropine. Glasses, patching and atropine. I think they're the key things that we have to combat this condition. There are those that like to talk about other alternatives for children doing their virtual reality games wherever they are in the home office or are in the Zen position on the couch. But I think the best evidence we have is patching works, patching is cheap, and patching can help at many different severities. And the Paediatric Eye Disease Investigator Group has got a wealth of studies and publications, which I don't have time to go through in depth, but to summarise a few of their studies, we know that if you patch for 6 hours, for a severe amblyope with vision less than 36, if you patch for 6 hours, it's the equivalent of patching all day. For a more moderate amblyope, if you patch for 2 hours consistently, you will also bring their vision up eventually as if they were patched for 6 hours a day. So there's a lot of evidence base behind the amount of patching that we should do. But what about that uncooperative 2-year-old who just refuses the patch or throws away the glasses when the patch comes near? In the atropine studies from the PD group, we've shown that atropine can improve the vision in the amblyopic eye, even in those with severe vision loss, that a fifth of them got better than 20/40 vision. And in the moderate amblyopes, a daily drop of atropine, or even perhaps better, because of its less likelihood of reversing the amblyopia, using the drops on consecutive days on the weekend is very effective at bringing the vision up in these kids. And it's very interesting that although the atropine may blur the eye, it doesn't need to switch fixation for the amblyopia therapy to work. There is also some success in older children as well, and I'll talk about that in a moment. But to summarise the application of the PEDIG studies, get the kids into the appropriate glasses first. When the vision stabilises, get into the patching of the atropine. 2 equals 6 hours for the moderate, and 6 hours is the sort of limit of what you need to do for the severe amblyopes. And you can attempt it for those over 7. Get them into whatever visual activities they'll take on board, but if you're doing less amounts, get them up working visually as early as you can. Parents might ask, should my kid be doing screen time with their patch on? Of course, if they can. Though there are things that they worry about, and their patching and their iPad use doesn't go well when they're visiting their kinder and running around on the outside as well. So what about Gav? He's 4. He's just moved to your area and has just arrived in your waiting room. He's disruptive in the classroom. He's disruptive in your waiting room. And his vision, if he tried, is very poor in the left eye. He's straight. His glasses are scratched and he won't wear them, but they are pretty close to correct. What are we going to do with Gav? Well, I asked my expert orthoptists, and we've got to engage the parents very early on in the process. We've got to make it a daily routine for Gav to get this patch on when he's not tired, when he's not hungry, when he's not worn out by his day in childcare. We've got to get him to engage with the visual tasks. So parents are going to have to take some time off here, or other caregivers are going to need to be found to help see the improvement. And if you can show the parents pretty quickly with a really intense month or two of patching that it's working, you'll really have them on side. Close reviews, encouragement, and lots of it. If we can give reward charts, if we can give a reward at the end of the week, a reward at the end of the month for all that patching effort, you're going to get these kids up and their vision flying. When it gets tough, you're going to suspect that the kids are not compliant with the patching. You need to change track. You don't just keep flogging a technique that's not working. Can you engage a different caregiver? Can you get the childcare or kinder on board? Is there more that you could do on the weekends when there's two caregivers around and perhaps they can give more time to the child to actually engage with them and not just think that they're doing their patching with the iPad in the room next door? When you finish or when you're getting close to equal vision, it's important to taper off the patching, not to go cold turkey and suddenly stop it. That will minimise regression in these kids. And also, there's a skill in knowing when's enough. For the older children who have really not improved over a couple of cycles, which I usually consider as 2 or 3 monthly reviews, and if they've had plenty of patching before, it is time to taper and it's time to admit defeat sometimes, or say that we've reached a ceiling of improvement. And I guess that's particularly in those that are strabismic or very high in ISO amblyopes. Just a couple of slides on the older children, because these are the group that get into the research
Jonathan,
studies.
one minute.
Yep. And the older children will improve to a small number, but particularly those who have had fewer hours or no prior treatment. The non-visual treatments, there's not a lot in the studies, even from the PD group, to show that they're going to help. And there's quite a bit of excitement around some of the dichoptic training and the binocular stimulus training that can be done for these older kids. They may have a benefit for those that are straight-eyed amblyopes from anisometropia. They use binocular viewing with either polarised glasses or colour filters. And the games that have been studied were really quite simple, and so showed very little beneficial effect, except for perhaps one of the earlier studies which had a younger cohort with less patching. The Oculopad, not tab, sorry, is another polarised pair of glasses that's been developed with more fancy games in mind, and recent publications have shown some benefit as well. So you might get asked about those modalities from those parents of kids who are not improving. But in reality, the binocular treatments are not more effective, they are more expensive, and if you can get these kids earlier and patch and give atropine penalisation, we will succeed. So early identification, initiate the treatment, engage the parents and the carers, and make sure you screen their siblings and the children of those with a family history of amblyopia. Thanks.
Thank you. Thank you, Jonathan. Our next speaker is Parth Shah, and he's recently established his base in Canberra and practices comprehensive adult and paediatric ophthalmology and strabismus. He supervises registrars at the Randwick Hospital campus in Sydney, and he's completed 2 overseas fellowships in both strabismus and paediatric ophthalmology in the UK and the USA. We now will hear his thoughts on managing nasolacrimal duct obstruction in children. What is the differential, when to operate, tube or not to tube? Thank you, Parth.
Great, thanks very much. We'll get straight into it. No financial interest, but I will be talking about some particular brand of tubes. So I'll talk about nasolacrimal duct obstruction in children, what else could it be, when to operate, and about intubation. Just some photos of kids that we have all seen, a few months old with watery, sticky, gunky eyes, often unilateral, but a small number can be bilateral. And they may also present at a much older age. Often they'll have frank watering and mucus build-up, especially medially. They might also come in with a history. This is one of Mum's videos showing me that the child has a bit of a mucocele and compression of the lacrimal sac leads to regurgitation. Here's an example of another child. So congenital nasolacrimal duct obstruction is the most common cause of a watery eye in childhood. It affects about 5% of all newborns. The symptoms we talked about earlier, and it's most commonly due to a failure of canalization of the distal nasolacrimal duct. There are some risk factors. We often see it more commonly in trisomy 21 and kids who have structural midface or craniofacial anomalies. There often can be also a family history of the same problem. What else could a watery eye in a young infant be? We always have to think about whether it could be a true conjunctivitis, which could be infectious. So it's important to look at the tarsal and bulbar conjunctiva carefully for injection and inflammation. One of the things to always rule out in the first month of life is a condition called ophthalmia neonatorum, which can be both sight and life-threatening. Another cause of progressive early onset myopia, which Dr. Rose talked about earlier, always think about glaucoma as a cause for both myopia and watery eye in an infant. And it's very easy to do digital, so with your 2 fingers, or eye keratometry in all infants that you see. Secondary causes of watering could be related to lids, cornea, allergic eye disease, and intraocular inflammation. So this is a 2-day-old child who presented to the hospital, and clearly that's not just a routine congenital nasolacrimal duct obstruction. There's severe purulent discharge. We don't tend to see gonorrhea very frequently, but this is the case of gonorrhea I saw a few months ago at the hospital. And this is both sight and life-threatening to the infant, so needs urgent treatment. Untreated gonorrhea can cause perforation of an intact corneal epithelium. This is another child that I saw recently with bilateral watery eyes, and mum says he's got really big, beautiful eyes. Interestingly, this child didn't have congenital glaucoma, but a rare condition called X-linked megalocornea, but just put that in there to look out for cornea and other disorders. Look at the cornea and the corneal diameter and think about glaucoma. Other causes include blepharokeratoconjunctivitis as a cause for watery eye. So we talked about some of the signs. We can do a dye disappearance test, which can also reveal things like abnormal anatomy and a fistula. If you think that the child may have a mucocele, which in the first couple of days of life is very apparent as a large blue lump over the lacrimal sac, then these need urgent treatment as they can cause respiratory distress due to intranasal cysts. We often see patients and parents coming in saying that the child's got conjunctivitis and getting sent home from daycare. True conjunctivitis is actually uncommon. In a large case series from the UK by Kari McCoon and her group showed that about 1 in 400 children with congenital nasolacrimal duct obstructions had true conjunctivitis. Dacryocystitis is extremely rare. It's important to look for, we've just heard from Dr. Roddle about amblyopia. An isometropic amblyopia can occur in about 10% of these cases, so it's important to follow them up and make sure that they have screening later on. I'll run through some of the other unusual and rare things. The slides will be up there and the talk's recorded, so you can have a look at them later. Always think about in the older child acquired causes, including canalicular scarring, mass lesions, and whether they've had any treatment for cancer. So in terms of when to operate, which is the second part of my talk, it's important to know the natural history because that's what parents really want to know when they come and see you at 3, 6, 9 months of age. The largest case series all sort of show that about 95% of them resolve in the first 12 months of life, and the remaining 5%, about half of them might resolve in the second year of life. So I usually operate about 12 to 18 months of age when conservative management's failed. Earlier if the child has recurrent conjunctivitis, which may be true conjunctivitis, or more commonly chronic mucopurulent discharge causing social concerns and a problem for the parents more than the child. I mentioned earlier that congenital dacryocyst needs urgent treatment. At some centres around the world, in-office probing in very young infants is commonly performed. I don't do this, and I don't know of many other colleagues locally who would do the same. Risks of surgery, obviously we'd like to do it under general anaesthetic, and surgery can fail. There is a small chance of creating a false passage. I won't go through the surgical technique in too much detail, but I do give them some vasoconstriction. It's important to check your instruments. Often the dilators and the probes that we have are many, many, many years old and they're still good, but check that the probe tip doesn't have any spurs. I have the ability to put a stent in available for all patients. Always teach the registrars the anatomy, and just remember the anatomy when you're probing. A lot of us do Jones test in the office for adults. So just making sure that you remember to follow the anatomy. So the reason that you can get a false passage, this is a good diagram from Leatherbarrow's book, is because a kink may occur while you're probing the canaliculus, or it may be due to a common canalicular obstruction. Generally, we feel for a sensation of a pop or reduction in resistance and check metal on metal with a larger probe introduced. And we may put a silicone stent in. So this is just flushing the nasolacrimal sac with fluorescein and retrieving it from the nose with suction. This doesn't, it's more to flush away it's not for checking patency, but for just flushing the sac. I use this particular brand of silicone stent, which I'm just sort of familiar with and trained in. It's a monocanalicular stent. It is secured at the punctum and no suture is needed. Postoperative care for most of these cases, whether or not you put a stent in, is very minimal. Drops are not really necessary. When to stent, based on my training and comfort, I tend to plan to put a stent in almost all patients. Most of the time I'm doing it over 12 months of age anyway. Why do I do it? Some might say that there's very little benefit in most standard cases, but it does slightly increase the success rate of the procedure. It does avoid a second procedure for the child, and the complications of putting a stent in are very rare. So these diagrams show you the actual stent. I don't have time to go into the detail of the surgical technique, but it's retrieved from the nose using a retriever, or you can use a nasoendoscope to visualize the stent coming in. That's what it looks like when the stent's in place in the upper punctum, and that's the same child seen in the clinic. Another other child. This is a stent in the lower eyelid. It doesn't irritate the ocular surface or cause any issues. The child doesn't know it's there. Remove the stent after 6 weeks in the clinic, just using a toothed forceps. Most children tolerate this very well. Sometimes a young wriggly toddler may need to be held by their parents. And that's one of my registrars taking a stent out just last week in the clinic. The length of the stent depends on the age of the child. So sometimes if you put a stent in an older child, it will be much longer depending on the anatomy. Why can the procedure fail? Often these children have chronic rhinitis or complex anatomy, some of the causes I mentioned earlier. Consider a mucocele or bony obstruction. They may need referral to an oculoplastic colleague. Balloon dacryloplasty is not commonly performed, at least locally that I know of, and they may need a DCR procedure. This is my last slide. A young infant often presents very happily with a blocked tear duct, and when you fix it later on, they're not too impressed. So just remember, you're often treating the parents and not the child. Thank you.
Thank you, Parth. Our next guest speaker is Anu Matthews, who's an experienced ophthalmologist specialising in paediatric ophthalmology and strabismus. She works at the Royal Children's Hospital, Royal Melbourne and Royal Women's Hospitals, and is very involved in teaching medical students, ophthalmology registrars, optometrists and GPs. And Anu will be talking on refracting in children and when to remove glasses with minor scripts, bifocals or multifocal lenses.
Thank you for that introduction. Can I ask you all to take your phones and go to the app, because I've got a few questions to keep you on your toes and make sure that you all are awake, and hopefully we can get more than maybe 5 responses. That would be great. So the objective of my talk is to determine which children need glasses and who don't need glasses, what's the information you require to prescribe glasses, and also to provide proper glasses to improve vision, promote binocular vision if possible, and also what's going to be tolerated by the patient as well. So indications for glasses, as you all probably know, high hypermetropia, high astigmatism, any significant anisometropia, esotropia with hypermetropia, and then we have a higher threshold to prescribe glasses for myopia because in young children their world is within arm's distance. But so any either high myopia or significant myopia after the age of 1 to 2, and in school age, obviously it's more important to treat myopia and have a lower threshold to treat that. And then we also prescribe glasses for aphakics and pseudophakics, but I'm not going to discuss that in this lecture. You all probably have come across the American Academy Preferred Practice Guidelines, and we have this stuck on the wall in the rooms at the Children's Hospital, and our registrars refer to this all the time, and I still refer to it at times as well. And I think it's a very good guideline of when to prescribe glasses. I think one thing that has changed for me over the last few years is my threshold to prescribe glasses in children with hypermetropia, and that's changed because of a couple of recent studies from the Paediatric group that I will go through in a little bit. So the information that you require to prescribe glasses for children, and age-appropriate visual acuity is very important, as my colleagues have talked about earlier. Cycloplegic refraction for all children, so even if children come in with a foreign body, they all get dilated and have cycloplegic refraction. Subjective refraction when possible, and it doesn't have to be a full subjective refraction, it can just be a subjective verification, and you can do this in children in a really good 4.5 or a 5-year-old, just to see which script gives them better vision. Very important to assess their alignment, and of course stereopsis as well. So this is the first poll. So the polls are based on children I saw in my clinic on Tuesday. So this is a 5-year-old boy with, the parents say that he closes his eye intermittently when he's focusing at things at near, and sometimes they might notice a misalignment, but they're not sure if it's in or out. The vision as assessed with Lear symbols, which is a linear test that sometimes is better than just a single letter test, was 6.9.6 in the right eye, 6.7.5 in the left eye. They had an esophoria in the distance, but had an intermittent esotropia at near of 18 prism diopters. They still had intact stereopsis, which means that their eyes are straight most of the time. And on RET, their prescription, their cycloplegic refraction was plus 1.5. So none of these answers, in the polls, sometimes there's no right or wrong answers. This is just to give you a prompt to think about. And, oh, whoops, that was my prescription, but can we go to the poll? So plus 1.5 is the glasses that I would have prescribed. But as I was going to say, you often see patients coming to you and are very confused because they've had different prescriptions from 2 optometrists and 2 ophthalmologists. And sometimes there's no right or wrong answers as long as you follow the basic principles. In this child, I would have started with 1.5 to see, because they obviously have an accommodative esotropia. They have a similar script in each eye. If the parents were very reluctant to try glasses, you could patch them, but I still think they have an accommodative component. And if you don't treat them, then once they start going to school, they're going to develop an esotropia that occurs more frequently and start getting worse amblyopia. You could consider a bifocal in this group if you measured their ACA ratio and it was high, but sometimes in the first instance, I probably would start with a 1.5. Can we go back to the presentation? So next case, a 5-month-old boy with an intermittent misalignment since the 2 months of age, vision with preferential looking cards, showed some mild asymmetry, and on cover test, there's a predominantly left alternating esotropia of 20 PD, full range of eye movements, and your cycloplegic refraction shows high hypermetropia of plus 8.5 and plus 9.5, approximately, because obviously the child is obviously moving, and so it's around that range. What would you prescribe for this child? No glasses, as they're too young, and you review them in 3 months. Would you prescribe plus 8 and plus 9, or would you cut back the script and give them plus 6 and plus 7? Can we go to the poll? Great. So it's interesting to have all 3 responses. Perfect. We can go back to the presentation. So I prescribed plus 8 and plus 9. So I think in children with esotropia and hypermetropia, it's important to prescribe their full prescription. And the only reason I cut it back by 0.5 was I wasn't absolutely 100% sure on my refraction because the child was moving. I think, you know, with such a high script, it's expensive to make these glasses. And I always tell parents, the children, it is a high prescription. They might take a little while to get used to them, but once they get used to them, they will love them. And chances are with esotropia, they will need their full script. So I don't start on a +6 and +7 that they're going to pay $400 for, and then you have to update in 6 months. I start with the full script. So the principles of prescribing glasses in children with an esotropia under 4, I give the full cycloplegic refraction. If there's a high ACA ratio with a potential for stereopsis, then you can consider an executive bifocal when they're young. In older children, some optometrists are really good at making multifocals, but they have to be with a hard design, so they have they change very quickly between the different prescriptions and a higher pupil center. So I'm very careful with which optometrists prescribe multifocals. And when prescribed well, they can work really well in older children when they know how to use the glasses appropriately. In younger children, I tend to use more executive bifocals, but this is if they have the potential for stereopsis. I think if there was significant amblyopia, and the parents don't really notice an esotropia at near, then I don't see the huge benefit of giving them executive bifocals. And then when they're older, you give them enough plus to maintain their alignment. Just trying to go back. Enough plus to maintain the alignment, but not to blur the vision, as I find some older children are quite sensitive to blur, and it is important to refine your glasses prescription with a little bit of subjective refraction. So the next question, a 4-year-old with monocular eye closure in sunlight and misalignment when tired or daydreaming, which is a very common presentation to our clinics. The vision when assessed with K pictures, slight asymmetry, 6.9.6 in the right, 6.7.5 in the left, and in the distance they had a right exotropia of 30, prism diopters at near and exophoria only. Some stereopsis still, because they only have a phoria at near, and the cycloplegic refraction shows a bit of astigmatism in the right eye, but plano in the left. What would you prescribe for this child? You could either give the full prescription and plano in the left, and I think for this question there is no wrong answer, and my colleagues might prescribe something different. You could over-minus them if they can tolerate it, or just correct the right eye, but cut back the astigmatism correction. Can we go to the poll? Great. You can go back to the questions. Thank you. So that was interesting. So I would have over-minus, and I don't over-minus all children. It's only if I know the child will tolerate it and wear their glasses, and we measure an ACA ratio in clinic as well, and if over-minusing shows to keep the eyes straighter, then I will prescribe it, but otherwise I wouldn't. So in exotropia, I think it's very important to correct any myopia and or astigmatism. You can consider over-minus, but we know that over-minus glasses doesn't treat the underlying cause. It's only a temporizing measure, and a lot of kids may not tolerate over-minusing as well if they blur their vision. So I only give over-minus glasses if they don't blur their vision and they need glasses anyway for other problems like astigmatism. And obviously, if they have high hypermetropia, which is potentially amblyogenic, then giving them better vision will control their exotropia better. So you prescribe glasses, but not fully correcting their hypermetropia. What about hypermetropia, myopia with no tropia? I think it's important, if the spherical equivalent is high plus, then I personally reduce the plus to about 80%. They don't need the full prescription. Moderate hypermetropia with no tropia, often children don't need glasses. And if they're myopic, as Lauren said, I give the full cycloplegic refraction. My change in practice for hypermetropia is based on the Paediatric studies that show that children can do very well if uncorrected, and you can just observe them. My last quick question, is it a good idea to decrease the amount of astigmatism prescribed to children on the first visit to prompt acceptance, true or false? And false. We don't need to go to the quiz for that one. I think it's important to give the full astigmatic correction, and this is my last quiz. So a child with significant astigmatism, which is the best glasses prescription? I might go straight to the poll. Oh, sorry. Can we go back to the questions? Sorry, the poll didn't have the answers. So you could either give the full prescription, you could cut back to plain on, and cut back on the astigmatism correction, or you could give a little bit of hypermetropic correction and full astigmatism correction. And again, I don't think there's any right or wrong answer, but this is my prescription. I think it's important in astigmatism correction to fully correct the astigmatism. Aim for the spherical equivalent of 0, but don't over minus, which is why I gave a little bit of plus, and most importantly, fully correct the anisometropia. When to remove glasses, low to hypermetropia with good alignment, vision and alignment. We see a lot of optometrists prescribing glasses of +1 and +2 when the children have good near vision, good distance vision, and normal alignment and stereopsis. These kids don't need glasses. There are no evidence for Shaw lenses, so kids can tolerate relatively large amounts of anisometropia and anisoconia. There's no reason to spend a few hundred of dollars to use special lenses. There's no role for segmental occlusion. And in children, there is very limited role of prisms. I would say if you saw a child with prisms, they probably don't need them. So hopefully I've achieved my objective and helped you just clarify when to prescribe and when to remove glasses for children. Thank you.
Thank you, Anu. Marie will talk about learning difficulties in children and the myths that surround vision as the main cause of dyslexia.
This is a massive topic and we can only really sort of touch the surface of it. But specific learning difficulties are unexpected, persistent difficulties in the areas of learning despite normal intelligence and adequate educational opportunity. They're neurodevelopmental in origin and have a genetic basis, and it's estimated that around 5 to 15% of all school-aged children will have difficulties across the domains of reading, writing, and mathematics. And of these, dyslexia is by far the most common. And the converging evidence suggests that this is indeed a language-based problem in that there is a difficulty matching the sounds of words, phonemes, with the written symbols of those sounds, graphemes, and so there's poor sound-letter correspondence. And importantly, it is by definition a problem in decoding single words. So if you can't recognise the word, it's very hard to extract any meaning from the text. It is a persistent, lifelong condition, and often there is a history of poor language skills and speech delay. It shares an association with other neurobiological disorders such as ADHD and autism. And importantly, there are consistently changes in dyslexics in the language-based areas in the left hemisphere compared to normal readers, and those changes do tend to improve with an intensive reading program. But dyslexia is often thought to be a vision problem, and a common one is the tracking disorder, which is often diagnosed by teachers, parents, and occupational therapists. But we don't read with smooth pursuit, as in from the left-hand side of the page smoothly across the line to the right-hand side of the page. We actually read by a series of saccades. 85% of forward saccades, and the length depends on the difficulty of the text. 15% of backward saccades for verification of what we're reading, and the fixation pauses in between is actually when the information is processed. But dyslexics read differently. They have shorter forward saccades, they have increased regressions and longer, more frequent fixation pauses because they're trying to decode the word. And these are similar eye movements to a beginner reader, an adult reading, say, a difficult text or in a second language. And so they are not unique to dyslexia. But the optoms have come up with the developmental eye movement test, which picks up these abnormal saccades, which therefore need saccadic eye exercises. But as I just pointed out, it is the reading ability that controls the saccadic pattern, not the other way around. And if you give a dyslexic reading material appropriate to their level of reading or in a non-verbal task, then their eye movements tend to be normal. And importantly, if you have a congenital eye movement disorder like Duane's or Mebius, where you don't move your eyes horizontally, you don't have an increased risk of dyslexia. Or if you acquire abnormal horizontal saccades, such as with a sixth nerve palsy, you don't suddenly develop dyslexia. Well, maybe it's then a poor focusing or eye teaming problem due to accommodation or convergence insufficiency. And for this, we need the low plus lenses, prisms and glasses, and vision therapy. And to me, this is a completely overrated diagnosis and rare in children. And the counter-argument to it is that children spend countless hours, often continuous hours, on their iPhones and devices looking at YouTube and videos, seemingly without any discomfort. And that also involves accommodation and convergence, just like in reading. And a recent report showed that children who'd had vision therapy for symptomatic CI were no better in their reading ability than the controls. Well, maybe it's a vision perception problem because these children do reverse letters and they do have mirror writing. But if you have a non-verbal task for visual perceptual skills, the dyslexic children's skills tend to be normal. And a meta-analysis of 180 studies showed that perceptual motor training had a negligible effect on academic, cognitive, or even the perceptual motor skills themselves, and a slightly negative effect on the reading in that the controls read better. Well, maybe it's the scotopic sensitivity syndrome, or what we frequently know as Irlen syndrome. And this purports to have a sensitivity to certain wavelengths of light which interfere with or give you visual distortions, which then give you difficulties with reading. Initially thought to be a retinal problem, then more of a visual processing problem, and more recently is morphed into a hypersensitivity of certain visual stimuli, such as repeated patterns like stripes, and called pattern glare. For this, we need the coloured lenses to filter out these offending wavelengths, and which then will improve reading ability and comfort. The problem with this one is that even though it's been around since the early 1980s, there's no evidence that this condition actually exists. There is no physiological correlate. There is no objective quantitative assessment that we can use to say that this child has Irlen syndrome. It is a diagnosis of exclusion that relies completely on self-reported symptoms and response to the coloured lenses, of which there's poor repeatability in the choice of lenses, there are placebo and gender effects, and any positive reports in the literature do tend to be anecdotal. Well, maybe it's a temporal processing disorder due to which causes a defect in the timing of eye movements due to a magnocellular pathway defect. And this gives fixation instability, poor smooth pursuit and saccades. The problem with this one is that by definition, as I said, dyslexia is a problem with decoding single words. So the timing of eye movements is completely irrelevant. And some dyslexics have M-cell defects and some don't, and some normal readers do. There are lots of other theories out there that are supposedly causal to dyslexia, which are even less convincing. So what is the treatment of dyslexia? The evidence-based treatment is the systematic, intensive, repetitive instruction in the areas of phoneme awareness, phonics, vocab, fluency, and comprehension as the most the effective way to teach a child to read. And a child does need to be taught to read. This does not come naturally. And the earlier the intervention, the better the outcome. So what's our role? Our role is to make sure there is no significant ocular pathology, such as high refractive errors, which hopefully would have been already picked up with the preschool vision screening. Explain to the parents that this is not primarily vision-based, but language-based, and send a letter to school. The child does not have a vague tracking problem or poor eye teaming or eye focusing, does not need eye tracking exercises, glasses, or vision therapy. If they're really struggling with their vision, a more formal assessment with an educational psychologist. And maybe also get the paediatrician involved. Does the child have a mild hearing problem? Are they mildly developmental delayed? Do they have attention issues, behavioural issues, emotional issues? There may be many reasons why a child may not read well. And finally, dyslexics obviously think differently and their brains are wired differently, and that gives them maybe a benefit in different areas, such as the creative arts. And this is a list of people that we know to be dyslexic and historically are thought to be dyslexic. And as you can see, it's a pretty impressive group of people to belong to. Thank you.
Thank you, Marie. Professor Mackey is the Professor of Ophthalmology and NHMRC Practitioner Fellow, and within RANZCO is both a council member and chair of the Professors Group. We're delighted that he will share his insights and his extensive research about UV damage in childhood. Thank you, David.
Thank you very much, and thank you for the opportunity to talk at this session. I have no commercial disclosures. I think the COVID pandemic has given us some really good examples of contradictory public health messages, creating a lot of trouble with confusion, and also giving some entertainers, those of you who watch Giggle and Hoot, would recognise Jimmy Rees, who has some fantastic YouTube videos if you haven't seen them. We've actually been giving slightly contradictory health messages about UV for quite some time, starting with the Life Be In It campaign, getting families outside and exercising, and then the 1988, we saw the Slip, Slop, Slack, Sleep, Slide campaign, where we were telling people to protect themselves, and there's some contradiction in this. And really, we're looking at the tale of two epidemics here, having to deal with the issue of myopia from a lack of outdoor activity and the problem of skin cancer from excessive outdoor activity. So the recommendations and conflict has actually occurred more with the skin cancer specialists dealing with the vitamin D deficiency endocrinology specialists. And we actually have many public health guidelines, and there's a review published earlier this year looking into these and trying to work out what is the rationale and consensus of what we tell people. Now, in eye care, we are actually balancing on both sides of the pendulum of how much sun exposure people could get. If we don't have enough, we have the risk of myopia. Also, there is a risk of increased keratoconus if you don't go out enough. If we get too much, we have skin cancer, which is very obvious to the eyelids, but also pterygium. And if we're going to balance this, this is the result of sun exposure years down the track. We looked at baby boomer aged individuals in the Busselton Healthy Aging study. And when we looked at the people who had skin cancer, only 11% of them had myopia. But the people who didn't have skin cancer, it's 22% had myopia. So really, is that the balance we have to look at? Are you going to be someone who chooses, well, I'd rather the kids got skin cancer later on, or would you rather they got myopia earlier? And this is a challenge of working out how to balance this. When we actually look at pterygium, although it can cause astigmatism, not many people with pterygium have myopia. And this is the only real data we've got in Australia, where we looked at Lions Outback Vision's refraction data. When we look at myopia in Australia, our earliest studies, the Blue Mountains Eye study and the Melbourne Visual Impairment study, they have rates that were pretty low compared to global comparators at the time. We've more recently looked at the RAIN study, the parents within that cohort, so similar ages between 48 and 70. We could pull from all four studies, as well as the Busselton study that I've mentioned. And you can see here differences between the city and rural populations, but also the recent studies seem to have higher rates. Now, this is even more complicated by factors such as cataract surgery pulling individuals out of the examination comparison. But you can see here that the generation 1 of the RAIN study has quite high levels of myopia, almost comparable to the UK Biobank, but they're probably a more educated and selected subgroup. But when we look at levels of high myopia in Australia, we do not see the same levels that are being seen in the UK Biobank. In Australia, the flip side, looking at pterygium, we pulled the Medicare data for pterygium surgery in Australia, and we could show that pretty much in every state, alas not for Western Australia, the pterygium seems to be falling, and this might be the flip side of all the sun protection campaign that we've seen here, the reverse of the myopia going up. And we also noted that there's a correlation that people who've had pterygium have a 40% increased chance of developing cutaneous melanoma. And this is an important thing we need to emphasise to people who do get pterygium, and young adults can have pterygium, that we need to make sure they're getting their skin cancers checked. Now, outdoors and myopia is very well established. There's great work out of the Sydney myopia study, but many other studies equally supporting this. We actually have high quality evidence coming out of Taiwan and China showing that increasing children's time outdoors decreases their myopia progression. Now, Gareth Lingham, who did a PhD with us in Western Australia, did a really good review article about what is the potential mechanism by which spending too much time outdoors can protect for myopia. And although ultraviolet light itself is proposed, it probably isn't the actual mechanism. So therefore, getting lots of sunshine but not getting UV is probably the best balance. We looked at a lot of markers of outdoor activity, such as skin mole counts, vitamin D levels, which tell you what happened in the last month or so, skin wrinkling on the back of the hands, and conjunctival autofluorescence developed by Minas Coroneo's team. And this is looking at this autofluorescence that appears on the conjunctiva, rare under the age of 10, but definitely developing through adolescence and early adulthood. And we've been measuring the area of this and then correlating this with a person's reported outdoor activity. This is the data from the RAIN study. And a fabulous study that we actually tapped into was a skin cancer prevention intervention done with schools in Western Australia. Some schools got increased intervention where the children were encouraged to stay indoors at lunchtime, to wear hats. No sunglasses, unfortunately, were documented during this, but we were able to track these people down in their late 20s and see what did the intervention in primary school lead to in their later myopia. And when we looked at the conjunctival autofluorescence and what was measured at the actual time back in the 1990s at age 8, 10 and 12, there's a definite correlation there with the later amount of sun damage measured on the eye. And when we pulled all this data, we could see that the individuals with the most measurements of sun exposure to the least actually had about a 2-hour difference per day of sun exposure. And this was the work that Gareth did, another publication that you can reference to. But not all children are the same. So the advice you would give for a red-haired, freckled child is not the same you would give for a child from South Asia who has highly pigmented skin. But I think the message we need to be given is not to be something that's contradictory. And I think the simplest way of get some time outdoors but don't get too much sunshine is to recommend children get lots of bright shade. So outside in the bright light, but avoid the direct skin cancer causing things. So keep to the slip, slap, slop, sleek, slide campaign. The probable recommendation is to wear sunglasses, but not dark sunglasses so that the illumination gets through. But we don't have the data on this. Hopefully in the future, and this is some work we're looking at in Western Australia, and hopefully to spread nationally, is to look at whether we can do the genetic risk profile of a child, whether they're not only going to get myopia, but the risk of blindness from maculopathy, retinal detachment or glaucoma, and then balance that with their genetic risk of skin cancer and pterygium. And then most importantly, look at their axial length trajectory. Is this child on a pathway to developing myopia based on their increasing axial length or being above the normal distribution? If they're looking like myopia and they've got lots of pigmentation to protect them from the sun, send them outside. It's the cheapest myopia prevention we have. If, however, they're fair-haired and at risk of skin cancer, that's where we need to be looking at other interventions such as low concentration atropine drops or the various refractive options. So in Australia, we're famed for our outdoor lifestyle and consequence of very high rates of skin cancer and pterygium. But if we look at the same picture from the other side, we are also having the advantage of this in preventing our myopia epidemic. But as myopia is going up, we need to look at what is the trajectory of children's axial length and come up with a personalised management. These are the axial length measurements of the children in the Western Australian atropine study, and you can see, although that's the pooled data above, we have the individual data on the bottom point there. And when we compare this group, and this is all our population studies axial length data, it looks like about 18 to 20 years of age is where it stabilises if you're emmetropic. However, if you are developing myopia, your axial length can increase in your third decade, and this was some work Sam Lee presented. And you can see there how the atropine for myopia cohort way above the population measurements. And I'd like to acknowledge many, many people who've worked with us, but in particular, Gareth, Sam, Seyhan, Maria and Vinay, who've worked on a lot of the recent data. Thank you.
Thank you, David. We'd now like to open up the floor to questions. The first question, David, is there a racial difference in Australia with regard to the pterygium and the incidence of pterygium, Caucasian versus Asian versus others?
The data that we do have is that Aboriginal Australians have higher rates of pterygium than European Australians, and that's going back to the early National Trachoma Program data, but also in our recent study with Lions Outback Vision, the majority of people with pterygium were Aboriginal, although it's only about 50% of the people being seen by the service.
Do we have any other questions?
May I just ask David a follow-up question? Is that because they spend more time in the sun, or because if their hours of sun exposure is relatively similar, is there a higher prevalence within Aboriginal population?
I think the more pigmentation you have in the skin, the more ability you have to be able to spend outside, and therefore you are at risk of getting more sun exposure. Even in Australia, an interesting finding we noted with the twins eye study when we compared how many blue-eyed people there were in Queensland in the twins study with Tasmania. There were more blue-eyed people in Tasmania. So I imagine their ancestors in the last 100 years, because the British government just sent you anywhere in Australia, they probably chose to go down and stay in Tasmania so they didn't get sunburnt as much as they would here in Queensland.
Can I just make a comment on the management of myopia? I think one of the things that's very important to explain to families is why we're doing it, and we're really doing it not so that they, don't have to wear glasses and things like that. Our laser refractive surgeons can fix that. But I think it's important we're playing a very long game, and we're trying to reduce their risks of glaucoma, macular myopic maculopathy, retinal detachment, and all of those things. And I think it's important, particularly with the children that are either high myopes to start off with or progressing and our treatments are not working, the parents can feel like, and the children can feel like they're failures. And they're not at all. But we need to explain that that's the long game. What we're trying to do is trying to get it within a limit which reduces those risks, so they don't actually put the risks down to zero. And we also have to give them a sense of hope that the future's unknown. We've got no idea what treatments we might have for retinal detachment, for macular myopathy, or glaucoma indeed, in 50 years, because a lot of these kids we're treating are primary school age children, and the diseases we're trying to avoid are going to occur when they're in their 50s, 60s, 70s and 80s. I think that's a very important message to communicate. Everyone's getting sort of hot under the collar about myopia, which is fair enough, and I think in the long term it makes a lot of sense, but we are playing an incredibly long game.
Quick question to Lauren. What do you do with the kids that are on low-dose atropine, but you haven't started them on the peripheral defocusing lenses? Because if they're at the high doses of atropine, so 0.05, and if you're a bit of a cowboy like me, I occasionally use 0.1, you can't use peripheral defocusing lenses if they're getting the side effect profile. So do you check them for side effects before?
Yeah. So, in the interest of time, I abbreviated quite a bit of the examination. But yes, so part of the assessment on follow-up, especially if you started any atropine, I would recommend checking their pressure. I would recommend checking their dilation. You ask them if they've been compliant, and that's obviously important, and tolerating. So I also check their near vision to make sure they're not having trouble with their near. And some will say they have some difficulty in the morning, but they don't notice it by the time they go to school. So there is obviously, even on the lowest dose, the potential side effects that can affect compliance and their everyday life. And again, we are trying to get them outside, so we don't want them to be uncomfortable with glare to the point of not going outside. So there's a whole lot of stuff that needs to be discussed. But if they are on a higher dose, I often check how dilated they are and ask them if they've put the drops in the night before, so I get an idea of what everyday life is like for them. If they're very dilated and they're symptomatic, I do think you need to start, as James said, looking at the bigger picture. We are trying to limit the progression so that they don't develop high myopia and therefore don't develop pathological myopia, but we're not curing them of myopia. So I do take a step back sometimes, and I don't know if going to the highest dose and causing a lot of side effects is the best long-term game. With the lenses, that is something that now we're having more and more experience with, but also newer lenses. Like I said, there's been a new one in 2 weeks. So we have more options than just the drops. So I think we need to be a little bit aware that we've got more armaments, potentially a lower dose and a combination with the lens. There's limited data on how effective that is, but there's also reasonable data from everyday life, and at least my experience, that it's very safe and possibly more tolerable than changing the dose of the atropine. We do know the higher the dose, especially with a lighter-eyed kid, will be more likely to have symptoms. So yeah, it's a combination, and it's a discussion, and potentially a little bit of a chop and start. But a patient that comes in with high dose atropine or higher dosed atropine than 0.01 and is doing well and not symptomatic, I don't automatically take them off it. I potentially just continue to monitor them.
And just another question, what do you do when you want to stop?
Tricky, because we worry about rebound, and we know the higher the dose, the more chance of rebound. So if we've got a higher dose, a patient on high dose, which is 0.05% in my book usually, I'm a bit more hesitant to stop, especially if they're just about to start exam period, and often they are in that 15 age group where they're about to do their year 11 and that sort of thing. I like to see their axial length progression slowing down. To me, that's an indicator of their natural eye growth slowing down, not the drops slowing things down, or the glasses. So then you know that their own baseline measurement of growth is hopefully slowing down, and that gives me an indicator to have a break. I usually have a 6-month break, and I actually then check the axial length looking for rebound, and occasionally have to restart the drops. With the higher dose, you can consider dropping it to a lower dose and then stopping. It does make the whole process really long and long-winded. That means patients coming every 6 months, and we're all pretty busy. So you need to sort of work that out for your practice, how much help you've got from your local optometrist, and what that age and risk factor. So if they're a very high myopia, you're going to be worried about that extra bit of growth that's going to happen if they get rebound. But if they're a moderately low myopia, you're not going to be as stressed, especially if they're older and they've been showing you that their axial length is slowing down quite naturally.
David, may I ask a question, please, regarding the sunshine and the outdoors activities? Sometimes I get the parents, but it's raining. It rains a lot in Auckland. So my suggestion now, I don't know whether that's fair or would you agree with it? Okay, open the curtains and read beside the window. Just let the light into the room. That's what I am. I keep saying, as you said, bright shaded areas. So it doesn't need to be outside. Am I right? Just get the.
That's the best compromise. So yes, please encourage that. I think that we need to look at having proper shaded play areas outside, and whether that's the carport at home that you take the car out of and let the children play under it, and definitely at our schools, although the shade cloths and shaded areas at school have been improved dramatically in all of the countries over the last few years because of the sun protection aspect.
Great, thank you.
David, while you got the microphone, can you see a time when a child wears a light meter on their vest and says, yep, this week I've spent enough time outside, I've got enough lux?
It'll probably be on their phone.
Yeah, exactly. Well, no, their phone's not good. It has to be something connected to them.
Avoiding the phone is a solution to something that's driving the lack of outdoors and increased near work, but it might be the way to go.
Russia, I just wanted to add that there is some quite reasonable studies showing that the lux of light indoors next to a window is not even close to in the shade outside. So I do think in a perfect world, a little is good, more is better. I do think, and I do say to my patients, you should be outside even on a cloudy day, and it's actually better and safer for your eyes than being inside next to a window. And if you're inside next to a window reading, it's a bit like going and doing exercise and eating chips at the same time.
Thank you. Am I correct, correct me if that the lux outside, it's 1,000 more than the inside, just for the audience, so you get the idea, it's really, we need really brightness.
I think
no, it's in a 1,000-fold,
Simple, 3 or 4 simple things I'll say to parents now. Part of my myopic consultation, which I could have just literally pressed the button for, and just, here's this video of myopia. But walking to or from school, so you're killing 2 birds at once with 1 stone for the kids. Get in the habit of trying to do homework outside if you can, you know? Like if it's summer now, it's actually easier. Third thing is getting a weekend outdoor sport. Kids then get socialised, get to do those other things. And then limiting screen time, unless it's related to schoolwork, to the edges of the day. So they've got reasons to do other things. Because a great lot of this is balancing those things. But we've just been 2 years indoors, and kids love socialising. They love socialising. So sports is a really good way to get it done.
But getting back to the lux, I think it's on the Ransco website or something, but wasn't it something like 100,000 lux on a sunny day, 20,000 on a cloudy day, and you need at least 20,000 to, slow down the myopic progression, and indoors was 500.
Yeah, no, it's not comparable. Parents keep thinking that if they just open the windows and have lots of windows, it's the equivalent while they're doing their study. You really need to debunk that, but be safe regarding UV exposure.
Can I just ask you, Lauren, with regards to compliance, if you've got a patient who starts the atropine, stops the atropine, what do you do?
Well, nowadays, if I have a really poor compliant patient, I usually try and avoid atropine. There's no point flogging something that is potentially going to do harm if they've got rebound or whatnot, or it's actually stopping their socialisation or going outside. I do think we've got some really good lenses now that we can prescribe. The rate of reduction of myopia progression is comparable to at least the low dose or the lowest dose of atropine. So it's actually, we've got exciting times to provide these other interventions. So we shouldn't be one intervention attempt. We've got all these elements, so we should be upskilled in all of them because it actually makes a difference into their socialisation if they can just wear glasses anyway but have myopia progression controlled to some extent.
Can I give some tips on some of the other things? So amblyopia, one thing that John didn't mention was using neutral density filters, and the easiest one of them is contact on the spectacle lens. That's quite a good alternative to atropine patch and glasses. You can add that. The other, with nasolacrimal ducts, one of the problems that parents often complain about is how difficult it is to keep the eyes clean while they're waiting to have a probe. And they also get some angular blepharitis and inflammation on the lower lid where it's constantly wet. So tell them to go and buy a tube of Lacrolube. They can keep it, the one tube, until they've had the probing, because you don't get bacterial contamination in ointments, or you can squeeze the first bit and it's gone. And just smear that a couple of times a day on the lid, and it's very easy to clean, and they get rid of a lot of the secondary skin irritation which annoys the children and the parents. High refractive errors, I'm cautious about prescribing, or in fact I never prescribe full astigmatism for high astigmatic refractive errors. And I start to call that anything over about 2.5 or 3. If you've got a child who presents with a -5 SIL, they won't tolerate those glasses, and I would tend to reduce that. I find it all the time.
And just on that point, James, just as we were talking earlier, please do topography or anything you have in the clinic for kids with high stigmatism. You might be surprised you could pick up early keratoconus, especially if they are eye rubbers or they have allergies or there's a family history of it. So it's always worth doing it. Just for
James, given that Lacrylube's out of production at the moment.
Oh, sorry,
do you
Polyvisc.
Thank
Yeah, it's the same stuff. Soft white paraffin, I should have said, and I shouldn't have mentioned the brand.
What about Vaseline? Would Vaseline be cheaper?
It stings the eye like crap. It's petroleum jelly. It's the wrong pH and stuff like that. So no, not Vaseline. So something that's designed to go in the eye. And the dyslexia, one of the things with dyslexia that I think is really interesting is the differences between different languages. So the problems in dyslexia in German are very different from the problems in English, and that's because it's a very regular, orderly language. And so a lot of the difficulties with dyslexia are due to speed and cadence and things like that, whereas what catches people in English, as well as all of the phonemic problems, but all of the irregularities. So as part of the skilled educational intervention children in English need is they need help coping with the irregularities so that they don't have trouble with the laughter of their dafter or the laughter of their daughter is a good example. And all the "oh you little devil" words, which are the would, could, should words, which aren't phonetic. And there's about 40 rules in English that cover all of those non-phonetic irregularities, and that needs to be built into the education program for children with dyslexia in a stepwise manner. The other thing with dyslexia that I think is helpful in older children who have ongoing problems, particularly if they have a component of dysgraphia, is to use voice recognition software and scribes. It makes an enormous difference. These people come across as klutzes because they can't write, and they're not that at all. They're just frustrated people, and they can generally talk the legs off a table or a chair, and they just need some help with that. So voice recognition software and scribes, particularly for assessments, are incredibly helpful. It extends their academic careers enormously.
And I'd just also add that English is a very difficult language to learn because it isn't often or always phonetic. Apparently, the best phonetic language is Finnish, of all things, and Italian is close behind. But English has a lot of, as James was saying, has a lot of words that are not phonetic and are sight words, and that's where that other thing of rapid autonomic naming comes in. You just have to recognise the word, and that's also part of the teaching as well. And I think we have a question from the audience.
Yes.
Oh, yes, it is working. I was about to really yell. It's Lindley. I work at Children's Hospital Westmead.
Can you speak up, please, Lindy? I can barely hear you.
That's a surprise. I'm normally very loud. I just was just a query really for the progressive myopes. We know how much some of these more specialised lenses can cost from a dispensing perspective. And also atropine for some families is also an economic cost to them. What happens with families, I guess, in the scenario where either option is really not a financial option for them? What is your suggestion for those families?
It's a very difficult scenario because you're quite right. The glasses, which are both different brands, are between $500 and $800, depending on who's dispensing. And the drops are on private script, so it can be expensive, and ongoing for a while. So yes, there is a financial issue that is there. Most of our public hospitals are not seeing the myopes that are progressing, given that we are already very understaffed and have a long wait time to see us. So bottom line is, it is a problem. I would normally give them the options of normal glasses. Obviously, they need to have good vision, and talk about the lifestyle, because I do think that that has significant evidence-based research to help them. I reassure them that, we are trying to avoid a high myopia / going into pathological myopia, and we did talk about it, but bottom line is these are all new therapies. Usually the parent is myopic as well, so they understand that they will still have good vision, with the right prescription, etc. So it's not a immediately blinding disease. As James said, it's a long game. But we do still need to tell them that these options are out there.
Thank you. Our session's up now, so I'd like to thank all the speakers and also the panel for their contributions. Thank you very much for attending.